All right, great. So we will be taking questions and answers. I did get a note that if you provided us with your email address at the front and when you signed in, that we will see what we can do about getting the slides over to you. So if you would like those slides, please leave your email address. We'll open the floor up for questions to any of our panelists.
I have a question. Hi, I'm Dr. Donnelly's. I work with colleges and universities on high-risk student behaviors. I have a question actually for Dr. Chaw on student drinking. In 1985, around about 1985, was the federally encouraged change in drinking age. And since that time, we've seen significant increases in binge drinking on college campuses, and while it's leveled off, we're now seeing more marijuana use. And so I don't want to do a correlation causation error, but I am curious about your thoughts on college age drinking, drinking age, et cetera.
That's a very good question. I don't have the data that might correlate perhaps an increase in marijuana use versus decrease in drinking. We do see that relationship in the data that I showed from the Monitoring the Future. I'm not sure that there's necessarily a relationship because there's so many other factors that it has to do with perhaps some cultural shifts. I know that the norms in my population of high school students and college students are profoundly distorted relative to what the NIAAA definition of a binge. There are culturally acceptable college behaviors around drinking and smoking. There is decreased tolerance for these types of behaviors within fraternities, dorms, generally on campus, which with much higher, greater punishment. I don't see that leading to behavior change in my patients. I just see them getting into more trouble. And this is not, I'm not blaming universities, but the mental health interventions that they provide are anything but robust. And because of various disclosure rules, it's very difficult to get parent involvement and support for college students who are essentially function as children. And the likelihood is that they have unaddressed comorbid conditions and they simply can't navigate the system without help. So it's a tough landscape.
I would agree.
Tom Berger from the Veterans Health Council. I'm a recovering academic, and I used to study high-risk behaviors. Been talking about a number of things. Are there what's the impact of what you've been talking about nowadays on teen pregnancy?
I guess from a developmental perspective, someone actually at RTI came up with a measure that can predict 1 year later not only your likelihood of initiating substance use, but actually your initiation of high-risk sexual behaviors, wearing a seatbelt, unintentional injury. So I think there's sort of profound interrelated developmental correlates that common interventions like the ones we've discussed today could impact.
Could be.
Other questions?
I did do some work with RTI a long time ago.
Yes.
I have a question for Dr. Powell. So going back onto your slide that says focus on racial and ethnic minority males, have you focused on Native Hawaiians? Just because you did say that higher suicide rates are amongst American Indians and Alaskan Natives, and culturally, they have similar backgrounds, especially with oppression. So what do you think of that, and do you have data on that as well?
So in my scientific area of expertise, I haven't focused in specifically on that population, but there are striking similarities with respect to the kinds of racialized trauma, historical trauma exposures that we see in African American males that we might see in more indigenous populations. So I think that the common thread there is that when we think about mental health issues and we think about substance abuse issues, we cannot ignore the context, the socio-historical, the everyday context, even the immediate proximal neighborhood environments and the implications of being in those environments for the decisions that boys and men make. So if I were to say anything, I would say that we need to lift that up a bit more, and there certainly needs to be more data collection from the populations you mentioned. I mean, we are embarrassingly behind the 8 ball because we have failed to measure appropriately the exposures, consequences, and outcomes for Native Americans, Alaskan Native populations too. So, thank you.
Another question? Yes.
Hi, Racialized. I'm also with Veterans Health Council, and I have a question regarding the policies, and I can't remember who put that slide up, but it talks about providing training to psychologists and other healthcare providers. Is there any plan to provide training for educators in mental health?
So I'm an advocate for providing training for every point of interface where boys and men are. And at the same time, I recognize that our educators are tremendously overburdened and overtrained. And we ask a lot of our teachers and our educators. So I want to be mindful of that. But with that said, there is a movement in the country, I think, not necessarily a new movement, but a reinvigorated movement around trauma-informed pedagogy and trauma-informed training for teachers, for police officers, for for every person that has a high touch with this population. And I think we do need more understanding, broad understanding of the ways in which mental health issues show up for boys and men relative to the ways they show up for girls and men. This gets back to the issues around diagnoses and why we perhaps see lower rates of depression but higher rates of suicidality. It could be, it's a complex, wicked problem, but it could be that what we're observing is the failure of our instruments to ask boys and men about their emotional lives in ways that would actually help us to have better early detection and early warning systems. So I think, yes, teachers, absolutely, but recognizing that we need everybody in the village to support this effort.
For training educators too, there's sort of 2 ways you can think about it. You can train educators in recognizing mental health signs and symptoms and making referrals, but you can also train them in underlying evidence-based practices that mitigate the likelihood of later mental health conditions. And I think it's like a both and. And for example, if anyone in the room is familiar with the good behavior game, yeah, some people are. So it's a really easy first grade intervention that teachers love because it dramatically improves sort of classroom behavior. And it has been shown now over following kids for 20 years to reduce levels of suicidal ideation, substance use initiation, depression, all sorts of stuff we really, really, really care about.
Yes, one final question.
I'd like to thank all of you for bringing awareness to the gender disparities, whether it's suicide, premature death, disability. What ideas do you have for increasing public awareness and public response?
So I'll just jump right in and say that I've been a big proponent, and there are movements for this that are happening around narrative disruption. I think we need, and I'm not talking just about your sort of run-of-the-mill public media campaign, social media campaign, but we actually need more constructive dialogue, public discourse around the issues that increased risk for mental health disparities. We need more public conversation, we need more truth-telling, and we need to create, I would say safe spaces are okay, but we need brave spaces where youth especially can come and air out what's happening in their lives. I think we're not listening enough as a country to our youth, and we want them to be seen and not heard, and I think that's a problem, and because we know these issues start earlier in the life course. So I'd like to see more of a sort of all-out sort of at every level public discussion, airing out of the issues that we're talking about today, and creating spaces where people can feel comfortable, safe, and sanctioned to be emotionally vulnerable.
Okay, great. Well, thank you all for coming and staying with us this afternoon. On behalf of the speakers and the staff at NIMH and our congressional sponsors, we want to thank you for joining us. And then also, please let us know if you are interested in learning more about the Men's Health Caucus, to invite your bosses to join us. You can come speak to me or to Taylor Hiddle of Congressman Mullen's office or Stephen Schultz of Congressman Payne Jr.'s office. Have a wonderful rest of the week.